So good morning, everyone. I'm really excited to welcome our Grand Round speaker for this morning, who is Dr. Tiffany Hebert. She is an associate professor of pathology at the Albert Einstein College of Medicine Montefiore Medical Center in New York. And she is the residency program director there since 2019. She is a graduate of Princeton, and I was excited to learn that she had majored there in Romance, Languages, and Literature, which I think is awesome. And then she went to Michigan State College of Human Medicine and received her MD degree there. That was followed by her APCP residency training at Albert Einstein Montefiore Medical Center, where she also did a cytopathology fellowship and then joined the faculty in that department as an assistant professor and as the associate residency program director. So she's now the full program director. And in 2019, she and her colleagues from the Department of Pathology there published a really interesting article in Academic Pathology about their new residency program curriculum at Montefiore. And I was excited to read this because it aligns so beautifully with the competency-based medical education that so many at medical schools are trying to put together. And so I really wanted to invite her here to give a presentation. So this morning we finally made it, and she's talking to us on training the next generation of pathologists, the Montefiore experience. Welcome, Dr. Hebert.
Good morning. Thank you so much for this invitation. As a fellow Midwesterner raised in Michigan, it's doubly important for me to be able to present this to you all. So yes, the title of my talk is Training the Next Generation of Pathologists, the Montefiore Experience. Hold on. And I don't have any disclosures. So the way I'm going to organize my talk, I'm going to start off by giving you an overview of what is new about the curriculum and how we organized it. And then I'm going to break it down into the various components of the residency training program, which actually began before the residents even stepped foot in our hospital with an onboarding program, which they receive online. That's followed by introductory boot camps that occur in the first couple months of the PGY1 year. We made significant adjustments to the way that we teach surgical pathology in order to enhance the ability of faculty and residents to interact on these rotations in a teaching format. And we also organized our didactics in a thematic fashion, which I'll go over with you. I'll also talk about some of the special didactics that we do that kind of cover many of the orphan topics in pathology, or those topics that are required of us for accreditation purposes by the ACGME. I will go into a very interesting focus in our program, which is the idea of integrating residents into clinical teams, interdisciplinary teams, so that they can learn more about their role in a healthcare team as a consultant. And then finally, talking about using entrustable professional activities as a methodology to advance more opportunities for graduated responsibility in residency training. So when we first implemented our new curriculum, which was in 2016, we were looking at data that's very similar to what I have cited here, which is from the ASCP Fellowship and Job Market Survey. This most recent survey shows that by the time residents reach their third or fourth year, they've already applied for fellowship, 82%. And most residents plan to complete fellowship, with up to 44% choosing to complete at least 2 fellowships before they enter the job market. And the reasons that they explain are that they felt that the job market would not accept them without having done those fellowships. And that may be related to the shift from a 5-year to a 4-year residency training program. And also that they may have needed that additional training for whatever specific job they want to go into if they want to be a subspecialist. But the other 2 reasons that were most common are a little bit more concerning. The first being that they want to enhance pathology skills that were not taught in residency. And the second is that they feel like they need to obtain additional sign-out experience prior to employment. Another thing that we had noticed, a trend, was that at least within our program, because this fellowship application process has really crept into, PGY2, PGY3, we felt that it was really having an effect on the residents' approach and focus. During their residency training years, some people would become laser focused on a specific subspecialty to the detriment of all other aspects of learning pathology. So we wanted to give people an opportunity to acquire a baseline of foundational skills and knowledge so that within their residency training program, they could already start to explore areas of subspecialty focus while they're still training in residency. And we also wanted to help them prepare for their role in what will become an increasingly diverse healthcare team, including not only physicians, but many non-physician providers, and potentially more interaction with patients in the future. And we want them to be prepared for that role within the clinical teams. So this is our curricular framework. And the foundation is actually the onboarding and the boot camp, which occur in the early months before and during training. And what we did was we looked at what the American Board of Pathology requires to be board eligible, which are 36 months of structured training in anatomic and clinical pathology. And we organized that according to a foundation, 24 months, where they are doing the core rotations that everybody thinks of: surgical pathology, anatomic pathology, autopsy pathology, and the core clinical pathology rotations such as microbiology, chemistry, molecular and cytogenetics, transfusion medicine, and hematology. As they advance to their third year of training, they're exposed to more subspecialty areas, and that's where we really integrated what we call hybrid rotations, which is where residents rotate on clinical pathology rotations, return to those rotations, but also start to become embedded within clinical teams. And then that allows them to have a fourth year that is fully customizable towards their career goals and an opportunity to subspecialize within their residency training. This is buttressed by our longitudinal didactic series, which I'll go into, as well as interwoven laboratory management and informatics training. We actually do have a 1-month laboratory management rotation, but it's also meant to be woven throughout various individual rotations that they get exposure to laboratory management questions. And the informatics training follows the peer curriculum and is a kind of a longitudinal curriculum that extends throughout the 4 years. So what that boils down to in terms of scheduling is shown in this schematic here. And this is a generic schedule. I actually do take pains to take into account residents' individual career choices. And if people are planning to go AP only or CP only, there would be modifications to this schedule. But the way it essentially is organized is the first year is more heavily weighted towards AP. And they do spend time in clinical pathology as well. And the reason why we made it AP heavy in the first year is because we feel that many of the skills and techniques that you have to do to function effectively in anatomic pathology are things that are not taught in medical school. So there's a lot of really hands-on tutorials and education that has to happen. And we wanted to do that as early as possible while people still, while the chief residents have time, while the faculty members have time early on in the training. They do a boot camp in clinical pathology as well in the first year, which is always centered in chemistry, and I'll talk about that later. This heme is, everybody doesn't do heme the first year. It could be any clinical pathology rotation. This is just a generic schedule. When they move into the second year, it starts to be weighted more. They rotate through all of the clinical pathology rotations, major rotations, and they spend time again in anatomic pathology and clinical pathology. As you can see here, I have listed selective. And what that is kind of a placeholder for me. And they actually can, disperse that over the first 2 years, 2 weeks each. And that allows me to be responsive to residents' interests and needs. So if I have a resident, for example, who says, you know what, I think I'm probably going to want to apply for a derm path fellowship And normally the schedule would have them come into DERMBAT in their third year. Well, I have an opportunity to get them into that earlier and let them get a taste and see if they want to do that. And then we can even make further adjustments to the schedule. So it's still rather flexible in terms of my ability to move things around. And then in the third year, they really spend their time, start going into more subspecialties. They spend time in heme path, and they start going to some of these hybrid rotations. And of course, the fourth year, as I mentioned, is what we call their customizable year. The way that this differs from what we used to do really is, a lot of it is with regard to clinical pathology. We used to have, we still had what we call an integrated anatomic and clinical pathology curriculum. You did a mixture of AP and CP throughout the 4 years, but they had very large blocks. So for example, your chemistry rotation was a 4-month block, and you would do that chemistry rotation and you would never come back and see it again. So one of the things that we had wanted to address when we started thinking about the new curriculum, we wanted people to have an opportunity to be exposed to the core content, but then come back to it at a later date and be asked to do more advanced things when they came back to it each time. So the program begins with onboarding, and that is sent out to them at the end of May. So pretty soon they'll be our newest match candidates will get this. And this is an online curriculum, and it's aimed at bridging the gap between medical school and residency, and also introducing them to us and, what do we stand for? What's our work culture ethos? And some of these citations here are from that same ASCP survey, and they queried the residents, and they found that a third of those who went into pathology residency felt that their medical school did not adequately train them for residency. 34% had minimal exposure to pathology in medical school, and another 35% had no real firsthand clinical experience in pathology. They had had the didactics and the basic sciences, or maybe done some laboratories, but they didn't know what the day-to-day work of a pathologist was. So we wanted to address that and allow people to start, everybody in the program start on a level playing field, that we know at least we've given you some content. So they have an onboarding that's online that they receive. And they get a series of learning exercises. It's a combination of videos and case studies, and it's meant to be as interactive as possible. So the videos go through basic histology, and they're Khan Academy style, no longer than 5 minutes. They're usually closer to 3 minutes in duration of all of the main organ systems that you would see. And then there's a series of case studies, which I'll go through in the next slide. They also have access to their schedule. They can see all of the lectures that are scheduled for the entire academic year. A little bit of what the rotation, the year-long rotation schedule is going to look like, all of the resources for the onboarding material that the institution, the documents that they need to fill out, they're also accessible through this site. And our chief residents compile every year an FAQ section, which kind of gives them information about, if I'm moving to the Bronx, where do I find housing? If I have kids, what are the schools in the area? What do they do for summer camp? Things like that. They have some tutorials on grossing, and also some basic tutorials on, how is a frozen section done? How do we decide, how long does it take to process the slides, things like that. And they also have an opportunity to contact me, the associate PDs, or any of the chief residents through this website. So when they go through the cases, they have just 3 cases. We didn't want it to be an overwhelming thing. We're asking them to do this in their free time before they even start residency. So they have 3 cases. Each of them, they use Google Slides as the format. They're no longer than 17 slides each. The first case is a hematology case. They get a clinical scenario of a guy, I think it's a guy with a head injury. He goes to the EG, they do a CBC. And then they learn, we use that as a springboard to talk about issues like turnaround time. What is a stat test? What are the various variables that could introduce sources of errors, whether they be pre-analytical, analytical, or post-analytical? And then we talk a little bit about some basic hematology principles. For the endocrine case, you have a patient who is hypothyroid. I think the patient eventually ends up having an FNA for a mass, and it ends up with a papillary thyroid cancer. We use that as a springboard, as a generic springboard to talk about things like QA, QC, again, sources of errors, the utility of an intraoperative consultation, and information about what critical values mean and how you contact physicians about critical values. And the third case is an autopsy case. It started off with someone who's actually diagnosed with some sort of pneumonia, and you have the clinical laboratory values associated with that. It moves on to death and autopsy, and that allows us to get into the discussion of cause, manner, and mechanism of death, how to report death, and when you should contact the medical examiner. With the onboarding, they get a self-assessment that they can do. And we also assess them independently. On the first day of residency, they get a pre-test. And at the end of their month-long boot camp, they get a post-test. And in analyzing a few years of these pre and post-tests, we actually identified that the retention of the material from the onboarding is very effective because it's that really interactive scenario. And actually that impacted the way that we organized our boot camp, because the boot camp used to be very heavily traditional lecture centered. And we were recognizing that when we did the post-test, they actually retained more material from the onboarding that had been done a month prior than what they were getting from those lectures that they were getting during the boot camp. We also have recently used the onboarding for transfer residents. We, for example, took a couple of residents from the Hahnemann program that had closed, and it was a really nice opportunity for us to just make sure that they still started at the same baseline as the other residents who are already in the program. So when they start, they have their boot camps. There's two. There's an anatomic pathology boot camp, that's what everyone starts in. It's a 1-month rotation. And like I said, we really tried to move away from didactics that were lecture-based and more into hands-on tutorials. So they have grossing tutorials in the cutting room. They initially start working on autopsies in small groups, two people, because we usually take about 5 people per year, 2 to 3 people. And they each person takes a step of the autopsy until they're able to go through the entire case, to do an entire case themselves. They do still have some traditional didactics about anatomic pathology techniques and processes. Like, for example, I give a talk on just like a generic, how do you approach a biopsy? How do you approach a large specimen? What do you do when you're when you're covering frozens? How do you make sure that you're prepared and you know what you're going to be dealing with? They get an introduction to QA and QM, and we start the informatics curriculum from the beginning of boot camp. During that time, they're working with senior buddies and faculty, and I'll talk a bit later about what we did to adjust the way that we worked with the faculty members and the residents during the anatomic pathology boot camp. For clinical laboratories, usually the 2nd or 3rd month of rotation, they go into clinical chemistry department. That's where the introduction to clinical laboratories is centered. It's meant to serve as an introduction to all clinical pathology, though. We use the chemistry as a baseline, right? So they learn about, with again, a combination of didactics and hands-on exercises, quality control. They learn how to review proficiency testing. They even go rounding with the phlebotomist when they go to do their blood draws. And they learn about regulatory structures such as CLIA, how our labs are organized, quality management, and an introduction to testing methodologies. So when we set about putting together our boot camps and everything, we wanted to also look at the way that our faculties interact with our residents. And I'll talk to you about kind of 2 separate ways, because when we first started this program in 2016, we still did general sign out. Everybody and every faculty member sign out everything. And you would generally have about 4 to 5 people on service on a given day, signing out all of the material from 4 different hospitals worth of surgical pathology. And what we did for that period of time was, during the boot camp period, we would designate 1 to 2 faculty members who would be teaching faculty. And they would rotate onto that service for 1 to 2 week increments. And what that meant, though, was for those faculty who were on teaching service, we reduced their sign-out load so that they could curate cases of high teaching value and really spend time guiding the residents through how to work up cases and teaching them. Obviously, that's very time and labor intensive, and it really, we knew it at that point, it was not going to be sustainable beyond a 2-month period, because we were overburdening the other faculty members who had to take up the slack on those cases. Since then, we've moved to subspecialty sign-out. And it's made it much more workable for us to continue to do this throughout the entire year, because all faculty participate. We know in advance which specialty residents are going to have residents. And for those specialties, we have faculty try to have the duration of time that they're on service in 1 week or 4-day increments, so that they're really spending a good chunk of time with that resident. And the reason behind that was we wanted to reduce the amount of interaction with multiple faculty members on a given rotation. Before we did this, you would maybe on a rotation, if say a 2-week rotation, the resident could have interacted with anywhere from 5 to 6 or even more faculty members, depending on the way the schedule was made. And it made it very difficult to track resident progress. And also, the residents spent more time trying to figure out each individual faculty's sign-out quirks and style, as opposed to actually learning the content of the specialty area that they were working on. So this really, I feel, helped to enhance the feedback and assessment of resident progress. We've seen an improvement in the evaluations that they get with more robust information, and also allows, I think, for better learning for the residents. The way that we organized our didactics, which I had mentioned before, I think is really kind of the backbone of our curriculum. They have daily protected time, 8 to 8:50 a.m. every morning. And the backbone of that is the Tuesday, Thursday series. It's a repeating 2-year didactic series, and that is a combination of things: lectures, slide conferences, interactive sessions. We've really tried to encourage faculty members to seek ways to do things beyond just lectures. But those are organized according to thematic sessions. So up here, for example, you have, this is 1 month's worth of Tuesday and Thursday sessions. This was a head and neck theme. They have a combination of anatomic and clinical pathology content during that theme. And each theme will usually have 2 unknown slide conferences in 2-week increments that cover the topic area as well. And sometimes if there's a cytologic correlate, they'll also do a cytohistology correlation. In addition to the Tuesdays and Thursdays, they have a variety of other conferences that take place with varying intervals. So there's the journal clubs and the unknown slide conferences. We've tried to involve our fellows in teaching as well. So each of the fellowships, we have women's health, heme, path, derm, cyto, and molecular. They all do conferences. They usually make them slide-based conferences. We do a biweekly next generation sequencing conferences, the CPC conferences. We have a few conferences that we do combined with our clinical teams, the heme, path, heme-onc, pulmonary, clinical pulmonary fellows, and we do a radiology correlation conference as well. All our residents present at interdisciplinary tumor boards. We do a monthly gross organ photography conference where they go through all of the photos that were taken of gross organs, and we look at the quality of the photographs as well as talk through how one should gross specific specimen types. And we also use that as kind of a QA function, because we ask faculty members who have identified issues with grossing to bring those to us, and we spend about 15 minutes going over a refresher on grossing skills. We have a weekly board review conference, and one of the things we started the last couple of years is integrating our residency program to connect with the medical school side. And so we have a monthly, or no, that's a weekly works in progress meeting where they kind of have an opportunity to collaborate and present their research findings. There's a lot of different topics that you don't think of as traditional pathology, but they are just as important for residency training. And even if you don't think they're important, I can guarantee you that the ACGME thinks they're important. So one of the things that we have incorporated is mentorship. We have a formal mentoring program. All residents are assigned a faculty member before they arrive. So first day of July 1st, they have a mentor. What we do is we look at what they have put down as their interest in their application when they apply to us. But we try to make it flexible, such that if at one point your career goals, you feel that it really doesn't align with the person that you were assigned as your faculty member, it's known that that can change. You can request a change, and there's no hard feelings from anyone about that. Diversity and cultural competency, I'm going to talk about that more in depth, as well as wellness. Communication skills is one of the things that we've been trying to push, because we think about all of the interactions that we have as pathologists, and it's not only interacting with one another and other clinicians, and now a variety of non-physician providers, as well as patients. So we wanted to give our residents the tools to interact in all of this different variety of settings. The tool that we use is a video media presentation skills conference, where the residents do a presentation which is videoed, and they actually have the opportunity to receive feedback in the moment on those presentations, but also have the video that they take home with them that they can review on their own. That's divided into 3 different sections. The first presentation is always a non-medicine presentation, and it's actually a great bonding opportunity too, because we get to learn a lot of things about our residents that we wouldn't otherwise know. So we've had presentations about photography hobbies, classical Indian dance, how to do natural African-American hairstyles. It's really nice, fun, low-key interaction. The next time they do their communication skills presentation, it will be presenting a quality assurance project. I'll talk about that in a second. And then the final one will be if they're going to present at a national meeting or a regional meeting, they have an opportunity to do the same scenario to present their talk there. We're doing, this year we're starting a social media training workshop. We have a departmental media content specialist who, she mans our Twitter account and all of that thing. And we actually have a few residents in our program who are Twitter verified people. So we're engaging them and our media content specialists to teach everybody, faculty and residents, how to leverage Twitter and social media to advance your career. We have a research curriculum that prior to this year was really based around Clinical Looking Glass, which is our proprietary data mining software. Residents would be trained how to use it, and then they would be assigned a faculty mentor and a quality assurance project at the end of their first year, which then they would present the next year at their video media presentation skills conference. We're moving on because that is no longer being supported. And so now we're being trained to use Atlas and Beaker Slicer Dicer, but those will be going on forward, and it will still happen in that first year that they'll go through that training and then be assigned a quality assurance project. Healthcare disparities, there's two things you want to work on with that. We want to foster research in that realm in our department. And frankly, the pandemic really helped to push a lot of that sort of research in our department. And we also want our residents to be aware of what healthcare disparities mean to pathology. Business of medicine, we really kind of piggyback on a lot of what the institution gives us to teach our residents about that. For regulatory requirements, we have all of our residents complete the laboratory inspector training by the CAP, and we also invite them to participate in inspection teams, whether it be the self-inspection or when we go to inspect other CAP laboratories. I mentioned the QA projects that are associated with the data mining software, but they also have individual QA projects that happen on individual rotations. And the informatics rotation I talked about briefly, and I'll go into more depth. So this is an example of what I mean about some of the different research that happens with regards to healthcare disparities. And they can be anatomic and clinical pathology rotations. Some of them were around the recent, this current pandemic. One of the things we're doing is just actually making that something that we publicize within the department to potentially drive more research in that realm, and showing people how they can use population-based research to do this sort of investigation. This is an example of some of the different quality assurance projects that happen on the various rotations, and we encourage them to present at meetings like ACLIPS, what some of the things that they're doing, and other national meetings. With regard to diversity, disparities, and wellness, we take a dual-pronged approach. We take advantage of what the institution and the institutional graduate medication office offers, and we also try to do some things in-house. So I am sure in Minnesota, you probably also had an explosion of interest in healthcare disparities and anti-racism around March, and we did as well. And so we've taken advantage of a lot of those interdepartmental seminars. There's a lot of activity in internal medicine, in some of the surgical specialties, and we invite our residents to participate in those seminars as well. The talent management is the platform that our institution uses for online education, and there are different modules that are within that, and we have our residents complete those modules, including things like on preventing discrimination and harassment in healthcare. We also believe that it's very important for the leadership to model that we value diversity. So we have our faculty and myself, all of those, have robust departmental participation in things that are happening at an institutional level to foster diversity, such as house staff mixers. For wellness, we do a combination of workshops and more providing awareness about what is offered. So we have a wellness office here, and they start off by meeting individually with each of our residents for what we call wellness introductions, where they're introduced to the employee assistance program. Additionally, we have a single page, like a one pager that we send out, that we actually give to each resident twice a year. Each time they have their semi-annual evaluation, they get the wellness resource page again, and just make sure that they get reiterated what is available for them. And then there's a workshop that's called Smart R, which is run by the wellness office. So I don't have to do anything except just set it up and send my residents to it. But it's teaching them techniques, like mindfulness and meditation, things like that, for stress management and resiliency training. As I mentioned before, for the informatics training, we use the PEER, which is Pathology Informatics Essentials for Residents. This is a curriculum that was a joint production of the CAP, the Association of Pathology Chairs and Prods, and the Association for Pathology Informatics. And it's a guideline, and we break it up into three ways in our department. We started off in the bootcamp, as I mentioned before, and that's a couple of didactics, two 1-hour didactics where they go over the basics of computers, networks, terminology, those sort of things. And then that's followed by a series of project-based experiential sessions that we select from the PEER toolkit. So if you look here, this is like the first 4 months of the year, for example. And as I had mentioned, they start off in anatomic pathology. So if you look in August, it's tagged to autopsy. And they just learn about how to create a database, and they actually use it to create their autopsy log and learn how to use the database to look for autopsies. Then we close the circle by following that up with seminar type discussions of principles and allowing them to kind of reflect on their observations from the various exercises that they did each month. Now, when we get to the third year is when we really start making what are the more non-traditional aspects of our curriculum. You do have the more advanced rotations, the hematopathology, and the various subspecialties, but we really start to try to bring them back again to the clinical laboratories in a different function, learning how to function as a consultant to clinical teams. So we have 4 hybrids, 3 of which are centered in clinical laboratories. The fourth one is the transplant pathology rotation. We have, in our institution, we do renal transplant, heart transplant, lung transplant, and liver transplant. So it's predominantly based in surgical pathologies, but they also rotate with the HLA lab and do rounds with the transplant team. The other rotations are based in the clinical laboratories. So they actually return to those clinical labs and get a refresher. And they also sit down with the rotation supervisor and kind of go over what they should expect when they go and interact with these clinical teams. What types of questions might they be asked to answer, or tests might they be asked to facilitate? So chemistry is paired up with endocrine pathology, and they are predominantly working with the clinical endocrinology teams. There is some option if they kind of follow the way the cases lead them. So occasionally they may end up in thyroid FNA clinic or doing something with surge path head and neck tumor board, but predominantly it's mostly in chemistry where the activity takes place. For microbiology, they're connected with infectious disease. And for hematology, they're connected with the clinical hematology teams. So when you look at breaking down the different clinical hybrid rotations, so for microbiology, they'll actually be rounding with both the adult and the pediatric infectious disease teams and the transplant teams. And they also rotate in the parasitology clinic. Their duties include holding the microbiology clinical fold, fielding consults and answering questions from the clinical teams. And there may be special projects depending on what happens during that month. So some of the special projects residents have done have been standardizing a drug MIC, writing up a case of the month, and giving talks to the clinical teams. And I've included some quotes from some of our residents about what they have experienced on this rotation. So one resident said, I was the first person that one of the pediatric fellows reached out to when they had an unexpected malaria consult, and I was able to follow up with them and discuss the clinical management. When they go to chemistry, they're rounding with the endocrinology team, attending their didactics and their grand rounds. And they consult with these clinicians on test selection, talking about expected turnaround times. And in this case, a resident indicated, I worked on many interesting cases. For instance, the first pediatric vape-associated respiratory failure in our institution that included microbiology, chemistry, toxicology, and later on, lung biopsies and forensic autopsy. So this resident felt that they had a better understanding of the reasoning behind test requests after they had completed this rotation. And hematology, they round with adult and pediatric hematology teams. They rotate in the sickle cell clinic, and they have the opportunity to participate in projects with our hematology teams. So for example, one was able to get involved in a clinical trial. So COVID obviously did have an effect on what our hybrid rotations looked like this year. Some of the rotations did not have in-person clinical rounding. Predominantly, that was the adult infectious disease. As you can imagine, they were a little bit busy at that time. But we did still manage to maintain contact with the clinical teams. It was just transitioned to a virtual format. And in the instances where there was a little bit less interaction with the clinical teams, residents were redirected to laboratory-specific lab management activities. For example, one resident was working closely with Abbott on addressing issues with new instruments and talking with the technical staff. I can't emphasize this enough that having these residents embedded in the clinical teams really drove collaborative research during this pandemic. This one resident says, after COVID, I would say my collaboration with the clinical teams doubled and included almost every division in internal medicine and PharmD teams, given the nature of the pandemics. Some of our residents have presented most recently at Eclipse some of that research that they did. We've, to this date, I think we have about 30 papers from the institution related to the pandemic, and a quarter of those have resident involvement. And most of those are collaborative involvement with medicine, hematology, and other services. So when we move on to the fourth year, after they've gone through these hybrid years and hopefully have started to be acclimated to taking on greater responsibility within training, we want to help them set up their fourth year of training. They are actually queried in the end of the third year with the survey and with meeting with their faculty mentor and myself and the associate PDs to create this schedule. And they are given choices that include both subspecialty and work environment tracks. So for example, somebody knows they're going to go for heme path fellowship. They already know they're doing that. They might choose to spend the bulk of their fourth year boning up. They might do clinical hematology and molecular cytogenetics. We see that a lot, that they try to fashion that year that way, so they really feel prepared when they enter the heme path fellowship. On the other hand, if say we had a resident who was interested in going into community practice, their year would probably be structured in a completely different way, right? We might advise them to do a couple of months in frozen section hot seat, for example, and spend a little bit of time in the more high volume areas of surgical pathology, maybe some time in transfusion medicine, taking call in that area as well. If somebody knows they want to be a laboratory director, we have some satellite sites that really give you what it's like, that experience to be in a community setting, dealing with everything on your own, and that's an opportunity for them to do that as well. So they start off with this self-assessment. They are asked to identify their strengths, their weaknesses, their career goals, to meet with that faculty mentor, communicate with myself and the associate program directors. And then we, the leadership, in turn, identify faculty supervisors for the special focus areas, because it is our goal that as they enter this fourth year, they're not just doing the same rotation that they would have done as a first year, not just coming back to surg path and grossing and whatever. Actually, in the fourth year, when they come back to surgical pathology, they don't gross at all. They're literally just signing out, and they manage the cutting room. They deal with whatever is happening in there, but they're not grossing. So we want them to function as a junior attending. They have, it's very important to identify the faculty mentor, because we want to really drive specialty track related scholarly activity and teaching. So we wanted to come out of it with, like, if you did a focus of 3-4 months in GI, that maybe you have a paper when you come out of it. Or if you didn't choose to do a paper, that maybe you have a really good canned talk that you can do if you're going to go and be invited somewhere to interview for a job, that you can have a talk that you are ready to present. Last year, I will admit, that was really disrupted by COVID. So that really didn't happen. They were not able to really complete that sort of scholarly activity in those specialty focus areas because of the shift that happened in COVID. But I was pleased to see that they were still engaging in research. It was just really all kind of pandemic oriented. we want to actually see more clinical interactions still continuing to occur in that fourth year. So rotations that have them engaging with the medical oncology team, or visiting the endoscopy suite if you're on GI, or breast radiology if you're on, if you want to do a subspecialty area, focus of area in breast. And then when they come back to clinical pathology rotations, or like transfusion medicine or heme path, that when they start taking call, they have more independence on those call rotations. And they also would play a greater role in approving test utilization for clinical pathology. So when we look at what happened last year, so last year's class, we had a very forensic pathology oriented group of people. So the majority of them were planning to go into forensic pathology. One was going into transfusion medicine, and one was bound for hematopathology fellowship. And we can look and see what they did. And the forensic pathology people really kind of tried to stay in the AP realm with that fourth year, the way they organized. They kind of, most of them tried to do a survey of general pathology, surgical pathology. One person was interested in perinatal and pediatric pathology. Some spent some more time in neuropath. The people who were going into transfusion medicine spent more time in hematology and blood bank. And like I mentioned before, the heme path people kind of did that kind of triad of hematology, heme path, and molecular. Some did cytogenetics as well. This year's class, we have one person who's doing the traditional kind of surge path, subspecialty focus, one who's going into molecular, and I think they may also be doing heme path, and another person is going into geopathology, and you can see the way that they organized their schedules as well. So we've only had one cohort of people graduate through the full curriculum. So we don't have much in terms of data yet, because we've only really had one class go through, and their year is actually extremely disrupted. We do have, however, some metrics in regarding to the satisfaction of the residents in terms of the way they perceive their residency training. And if you look back to the year when we started this curriculum, in 2016, there would have been only one class year of people who were actually in the new curriculum. Everybody else was still in the old. And you look at this green and the purple are the people who are either neutral or dissatisfied with the program. And we've kind of been able to eliminate the people who had a really negative viewpoint and increase the amount of people who had a positive to very positive impression of the residency training program. So yeah, what happened during COVID? We have, obviously, you know, we were the first hit here in New York, and we had a cessation of all elective surgeries mid-March, early March. So surgical pathology was gone. We shifted our work by early March. We converted all of our didactics to virtual didactic lectures and conferences. Obviously, we implemented all the requisite safety measures, remote sign-out opportunities, reduction of face-to-face time if you were, you know, still covering the posse or frozen sections that came in at that time. Our residents were shifted to the laboratory medicine side of things. We did have one resident actually who was medicine trained who volunteered to go to the floors and actually became an internist again and was treating people in the ICU. But the rest of our residents stayed within the department, and they were working on assay validation. They validated and verified over 7 COVID-related laboratory assays. They assisted in the development of novel pre-analytical workflows for specimen triage. We had an entire COVID command center where they could field questions and concerns for all staff. And so our residents were heavily concentrated in transfusion medicine, hematology, coagulation laboratories, and that sort of redeployment during that time. I will say, though, that actually having the way that our curriculum was organized gave me a lot of flexibility. I was able to give some of that time to laboratory management because they were functioning as lab managers at that time, doing like day-to-day work in that function. And rather than cannibalize required rotations, I was able to say, okay, well, you may have a reduced amount of elective time in the fourth year, but you're not losing your required rotations. So COVID really forced us to step up some of the progress we were making towards using digital technology in the first place. We had already purchased a whole slide imager prior to COVID, and it really impressed upon us the need to have access to that sort of technology. We're moving all of our teaching slide sets to the virtual slide server, and eventually we'll start to be to try to use it for medical school electives as well. One of the things we're going to be working on is adding to our onboarding just 3 cases. There will be a biopsy case, a small resection, like a gallbladder sort case, and a cancer resection case, where they'll be able to access virtual slides and practice how do I write up one of these cases? How do I check the little bit of identified clinical information we'll give them and the gross description, that sort of thing. We were already using ExpertPath and ImmunoQuery. We added on PathPrimer, which is essentially the same thing as ExpertPath, but it just allows them to use questions. It's got a question bank, which are books that already exist, but they're in a digitized format that they can access those. We subscribe to the ASCP question bank and the Laboratory Management University. That's actually one of the tools that they use while they're on the lab management 1-month rotation as well. There was an explosion of free content during this pandemic, and I really hope that does not go away, that we have the ability to continue to offer those things to residents. And some of our residents actually even produced some scholarship on this. They were using Google Classroom. If any of you people have children like I do, younger children, you know what Google Classroom is if you've been using it for your kids at home. But it's an opportunity, it's a platform to share information and interesting cases. For our didactics, we use mostly Zoom, and we also, for sign out, use Microsoft Teams, because all of our faculty members have digital cameras associated to, on our scopes, and you can easily link that to Microsoft Teams and do a sign out session that way. One of the areas that we are really focusing on going forward is looking at ways to increase graduated responsibility for our training. I think that will really get at that issue of people feeling like they needed more experience, that they weren't ready to enter the job force after residency, because it's a strange cultural thing within pathology that we just don't let residents do anything on their own. I mean, we have some things that are built into our curriculum inherently. As people progress through surgical pathology, they go from a lower caseload to a higher caseload as they become more senior. We transition from discussing ordering stains to allowing residents to order stains on their own, such as special stains, immunostains, and the workup of cases. Obviously, senior residents play a greater role in supervising and teaching junior residents, as well as supervising technical staff in the grossing room and clinical laboratories. Autopsy is one of the areas where you get really early independence, because once you've learned how to do the technique on your own, there's pretty much nobody's hovering over you in the autopsy suite. As well as reporting of critical values, interoperative consultation results. That's something we usually let them do kind of early on. Transfusion medicine, when they first start out, it's very, very highly supervised, and we would expect that as they progress, you can get a little bit more hands-off in terms of the supervision. Well, one of the things that we are investing is we're going to participate in a national multi-institutional and trustable professional activities pilot study. The study begins this July, and Bronwyn Bryant at University of Vermont is the PI. And what we are looking at are using the entrustable professional activities for autopsy, broken down into 2 parts, from reviewing the case, the patient's clinical history, to the PAD. And the second part would be from PAD to FAD. The frozen section, also into 2 parts, the technical component of the frozen section and the interpretive component. Transfusion medicine, the EPA for that is evaluating a transfusion reaction. And hematology, when the assessment for that one is related to working up a peripheral smear. And we feel that these assessments can be used to drive graduated responsibility activities. The way that the EPAs are set up for this pilot study is in 2 fashions. One is multiple formative assessments that take place. So about 2 to 3 per block or per rotation, that would end up that you'd have a bulk of them that you could put into a summative evaluation. And the summative evaluation is the level of entrustment you would give to that resident to do this procedure or this task with limited or no supervision. So in general, you don't have to participate in this pilot to create your own EPAs. EPAs are looking at discrete, task-oriented type real-life scenarios, things that we do that form our job responsibilities. And do you have the competency to do these things with limited to no supervision? they're really nice because when you actually have an EPA, you can actually give the residents the instruction, provide them with the rubric of how they will be scored for evaluation in advance, so they know what they need to be reaching. Usually, you would hope to have real-time, real-life scenarios, but some things you could probably try to do with simulation experiences as well. Actually, before we entered this pilot study, we were already using industrial professional activities for frozen sections. We used the checklist format and we tagged them to the competencies there. You can see like patient care, medical knowledge, systems-based processes, those sort of things. And ours are focused only on the technical aspects of the frozen section preparation. You actually had to pass that before the end of your boot camp in order to be able to independently cut a frozen. Other EPAs, we actually already also have a malaria identification EPA that happens in the microbiology rotation because that's one of their call duties. But some other examples of things that could be used, we talked about the transfusion reaction workup one. Many of the peer curriculum projects could be turned into EPAs. You could do an EPA for finding aspiration biopsy technique. I think though, for diagnostic surgical pathology, it's kind of hard to do it as a one-off. It's more likely to be something that you would do as a review of multiple reports and diagnoses by a resident over a period of time. So our goal is to, in the future, use entrustable professional activities to inform our milestones. They're actually tagged to various milestones that are provided by the ACGME, and use those to drive more opportunities for graduated responsibility within the residency program. So if you pass your transfusion reaction workup after multiple instances of formative evaluation, and the final summative says that you can do this with independent or indirect supervision, that's allowed, you get your check off for blood bank call. That if you were on hematology, hempath call, that you would potentially have the opportunity to make more decisions in terms of the flow panel choice, having passed this EPA, and obviously for frozen section and so on and so forth. The idea would be that you would have, we use New Innovations as our tracking for all of our resident data. So you're a faculty member, you're on call with this resident that night, and you, similar to the surgical specialties, this is what they do for their surgeries, you check online, where is this patient in the entrustability rubric, this resident, okay, and you're not beholden to that, right? It's obviously what you feel comfortable as well. But if you've seen that and you see that they've been assessed multiple times and you feel comfortable, this is the level of entrustability that you'll give to them. Some of the questions that arise are, okay, what happens if you fail an EPA? I think the idea is to use it more of a, if you're using it as a formative evaluation before you get to the summative, then it's fine. You don't want to be in a situation where you say, okay, you can't advance to your next year because you never passed this EPA. You want to give opportunities for the person to improve. And likewise, it's an assessment of how are we doing in teaching our residents, because if we routinely have residents who are not meeting the standard to practice at an independent level, then maybe that's just something about the way that we are teaching the material. I think I'm at the end of my time. And I would just like to give my acknowledgements to the leadership within the pathology department, because that is actually the key to us being able to implement this residency curriculum, was that we had buy-in and leadership from the highest level, from Dr. Stowski, our chairman, and my former program director, Dr. Steinberg. It required a lot of working with many of the people within the faculty of development, telling them what our reasoning was, involving the faculty in the development of the curriculum as well. We had a curriculum committee to set everything up. So it was definitely a team effort. Thank you very much.
Dr. Hebert, this is John Crossan talking. I really enjoyed your presentation. Thank you so much. I have one comment and two questions, if I may.
Sure.
And as you know, there are very simple requirements for residency training. The residents have to be exposed to 18 months of AP and 18 months of CP, and they have to be exposed to all of the subdisciplines, but it's not necessary that they all get exposed to the same amount to the subdisciplines. For example, if a person has a PhD in microbiology, they probably don't need as much microrotation as somebody who has no exposure to it. One of the questions I have is that you commented on some studies you had about retention following active learning versus 50-minute lectures. And I wonder if you could comment a bit on that. And my last question is, do you think we should get rid of the division between AP and CP?
Okay. Yeah, so when we did our assessments, so I think the onboarding program preceded the new curriculum by maybe 3 or 4 years. And at that time, but we still had a boot camp. And the boot camp was really, you would just get lectures. And some of this, I'm not really citing studies, but I have experience also from teaching at the medical school level, where we're also making a push towards active learning as well. And what we found was that when we would test, we would do the post-test, and the post-test covered both content from the onboarding and from the didactic series that happened during the month of boot camp. And I guess maybe you could also say that there was the impact that maybe they were just so busy during boot camp with everything else that they also didn't retain for that purpose. But even within the boot camp, there were some hands-on lessons as well. Without exception, they scored more poorly on the areas that were a lecture format. Yeah. And they had better scores on the topics that were covered in that interactive format. And that's why when for example, when I give lectures now to the residents, I don't really do a lecture per se. I send out papers for them to read, or I tell them, this is what I'm covering. This is where you get your background information of topic, the basic diagnostic criteria, et cetera. And we're going to go through some cases. And then at the end of those cases, we're going to go through some questions. And I try to make it interactive in that fashion, as opposed to me just reading an outline of, all the different entities you could possibly see. And I try to make it a lot more real world for it. And I don't know, when I see my evaluations that I get back from the residents, they're all anonymous. I don't know who evaluated me, but they're very positive, and they specifically cite that they appreciate that format. The second question, please, what was the second question about?
Should we get rid of
the
division between AP and CP?
I think the more opportunities that we have to show how intertwined they are, the better. And that is actually one of the reasons. Before we redid the didactic series, it used to be you would have Tuesday was AP, Thursday was CP. And they often had absolutely nothing to do with one another, the different topics that were even covered. And we really try to show now how interwoven one another are. So when you have your neoplasia in the various things, there's always, for example, a molecular talk, and he does it in a case-based scenario. He doesn't just talk about molecular, he talks about the histology as well, and the various things that were seen in the patient's history. So we really try to show that to people. I did want to also comment quickly on what happens when I have an AP only or a CP only resident, because we do have some. One of our recent graduates was AP only, and the way that I adjusted her schedule, everybody comes in AP CP only, but I ask people to, if they have an inkling, they know they're going to want to do AP CP only, let me know, because I can adjust your schedule as such. Even those who are AP only, they don't just do AP. I said, you still need to know how to manage a laboratory. You still need to have some understanding of clinical chemistry. You're going to be doing toxicology. You still have to have some understanding of how molecular pathology works. So they do still do some of these CP rotations. They're required. We just set something up in accordance to what we know that they want to do with their career. But that's another thing to think about, though, is that idea of we're still kind of tied into these the amount of weeks, even though the board tells us that we can sign off and say, yeah, we know that they went through this and they're competent based on competency. That if I had, for example, that person who came in with a microbiology PhD, I haven't pushed us yet to that. level yet. And I think that really requires robust evaluation of the residency, right? Because if we don't have that, it's hard to track that they've reached that sort of competency.
Yeah, so Debbie, I have a question, and thank you very much, Dr. Hebert. That was quite an engaging talk. I enjoyed it. I'm interested in your graduated responsibility thing, and I see that one of the things that you involve the residents in is in frozen section. And I'm just wondering whether that is just frozen section during daytime or after hours frozen section for things like donor assessment and everything. So what's your experience that in covering that, especially as it relates to graduated responsibility?
Sure. This is I'm going to tell you it's a work in progress, because at this point in my department, I would say the experience for residents in terms of the amount of responsibility they have on frozens is variable. It depends on the faculty member. Yeah. And the reason for that is, again, assessment. And I'm hopeful that once we have this pilot underway and I can actually have documentation that people can see, that they'll feel more at ease with giving people these responsibilities. But for those of us who really do try to give them more responsibility, this is what it boils down to. When they first start off, it's very heavily supervised. You know, we're in the cutting room with them. We're at every step of the way. But we expect that as they acquire more expertise, they are given the opportunity, for example, to choose the section on their own of what should be frozen. That they get away from the cryostat, and the PAs maybe cut that frozen, and they come in and take the slides themselves and assess and come up with a diagnosis without the attending. I literally have asked residents to go into another room and look at the slide and come back and tell me what you think, because often they sit there. Otherwise, they sit there passively and just listen. And then in terms of reporting, they go from listening to the faculty members say what the report is to the clinician on the other end of the telephone, to reporting it themselves, but the faculty member is still there, kind of listening to what they say, to be allowed to actually report it themselves without the faculty member in the room, come back and say what you told them, that sort of thing.
Yeah, thank you very much.
That's wonderful. Thank you so much, Dr. Hebert. It was a wonderful seminar, and I'm sure we have so many more questions. We traditionally finish these exactly at 9 o'clock, but we are really excited by your program. I'm just overwhelmed because you said things I didn't really know. So thank you so much. We really appreciate it.
Thank you. It's my pleasure. Have a great day.
You too.